outcry about the state of the country's main referral hospital, the Princess Marina Hospital in Gaborone, about the conditions and the quality of treatment accorded to patients seeking health care there. This report relates to an investigation into shortages, delays in human conditions, systemic breakdowns, particularly with concern relating to concerns reflected in the media reports that could not be dismissed as isolated incidents. At the center of any healthcare system are communities that the system serves, and the developments around the failure in the system reflected a widening gap between public health expectations and the lived reality of service delivery. This situation emerges at a critical time when the Office of the Ombudsman has been converted into not just administrative justice investigation entity, but also as the National Human Rights Institution. In that context, I am presented with a matter of significant public interest requiring for an human rights approach to allegations that appeared in the various media houses, amounting to what we perceived at that point to be maladministration. The investigation represents an urgent response to these allegations and also a defining moment for the Office of the Ombudsman, being a key accountability mechanism in this republic in respect of both maladministration and human rights protection and promotion since July 2023. We took this investigation due to persistent media reports over the years, and which reached a watershed moment with the publication in the Midweek Sun newspaper of the 27th November 2024, relating to allegations of total collapse of emergency room services at the Princess Marina Hospital, with a story entitled Princess Marina ER Ward is Hell on Earth. During the course of the investigations, it turned out that what we witnessed at Marina through the media reports was merely a tip of the iceberg, with problems emanating from and affecting feeder hospitals services and other support functions such as the central medical stores. As a result, the Office of the Ombudsman, pursuant to its statutory mandate to investigate issues of public concern involving human rights and administrative failures, initiated an own motion investigation. That is, there was no report to the Ombudsman, but that having looked at the concerns, we moved on our own to conduct an investigation in terms of Section 10, subsection 1, paragraph 2, and subsection 10, subsection 1B2 of the Ombudsman Act of 2021. The investigation was scoped to cover the generality of the public health sector, with specific focus on emergency room services. The Ministry of Health graciously did not contend or deny the challenges that they were facing. They magnanimously acknowledged the deficiencies in the competency, capacity, and governance of their systems, which significantly contributed to the deterioration of the health service delivery over the years, affecting and impacting on the health of Botswana at large. The investigation assessed administrative actions against national legal requirements and international normative standards to determine whether administrative conduct was lawful, proper, and aligned with the country's human rights obligations. A district level sampling methodology was applied, focusing on 17 public hospitals selected due to their central role in the health system, accounting for more than 60% of the public hospital beds and public expenditure in the health services. Whilst the investigation did not fully apply the World Health Organization's health system performance assessment framework, its principles, that is those of the framework, relating to access, equity, efficiency, and quality, shaped the methodology of our investigation. As the Ombudsman, I recognize that the shortage, inadequacy, mismanagement, and systemic fragmentation of Botswana's health system, culminating in the declaration of the public health emergency, necessitated a thorough interrogation of the right to health and the role, duties, conduct, and omissions of relevant office bearers. I must hasten to point out that the Constitution of Botswana does not expressly articulate the right to health as a right under the Bill of Rights, which guarantees fundamental rights and freedoms. But that, read together with the Public Health Act, the national health policies, and various other legislations such as the Children's Act, under Section 15 of that Act, we acknowledge that there is a modicum of a right to health that we must necessarily assume. I want to point out that internationally, Botswana has ratified several human rights instruments, including the Convention on the Elimination of All Forms of Discrimination Against Women, the Convention on the Rights of the Child, the Convention on the Rights of Persons with Disabilities, the African Charter on Peoples and Human Rights, and the African Charter on the Rights and Welfare of the Child, and has committed to Sustainable Development Goals, particularly Goal number 3. However, the absence of ratification of the International Covenant on Economic, Social, and Cultural Rights, being the key convention explicitly recognizing the right to the highest attainable standard of life, limits enforceability of the right to health in Botswana, even though we also add that Botswana is bound by the customary international law regarding the right to health, particularly in the background of the Universal Declaration of Human Rights. I have mentioned various rights or conventions to which Botswana is a party, because read together, the framework referred to support a proposition that the state bears the obligation to respect, protect, and fulfill an entitlement to a healthy standard of life by all citizens, thereby laying a platform to assert that there is a right to health, that the state must ensure the availability, accessibility, acceptability, and the quality of health services without discrimination or undue treatment of anyone within this country. It is within that context that this report proposes that the right to health is an essential to human dignity and aligned with the global understanding articulated since the 1946 Constitution of the World Health Organization and further elaborated in the General Comment number 14 of the Committee on Economic, Social, and Cultural Rights. Botswana's health system is structured across 27 health districts, with the Minister of Health as the apex body, coordinating responsibility for overseeing the national health policy strategy and oversight. District authorities deliver primary health care through a network of health posts, clinics, primary and district hospitals, whilst tertiary or referral services are provided at Princess Marina Hospital in Gaborone and Nyangagwe Hospital in Francistown, as well as the psychiatric hospital, Sabrana and Lubadzi. Our focus is going to be on the two referral hospitals, being Princess Marina in Gaborone and Nyangagwe in Francistown. Public health care, including hospital care, medicines, and laboratory services, as you largely know, is provided free of charge to citizens, save for a very nominal fee that over the years has transpired not to be compulsory. The investigation set a core of issues, informed initially by the allegations received, and later expanded through evidence gathered during the inquiry. These issues included, and I enumerate them, whether the provision of ambulances and emergency medical services is adequate or inadequate, resulting in delayed and inaccessible emergency care, whether shortages of hospital beds constitute a failure to meet international obligations to provide sufficient health care infrastructure, whether staffing deficits in emergency and other clinical units reflect inadequate allocation of human resources necessary to fulfill the right to health, whether the available budgets and resources are sufficient, and if so, whether there are mismanagement of the proceeding contributed to service delivery failures and hindered the progressive realization of a right to health, and whether shortages of essential medicines and non-medical supplies persist across facilities, and whether weaknesses in complaints handling and follow-up procedures deny patients access to effective remedies and accountability where there are instances of maladministration, and whether this could constitute a violation of the right to health. The investigation enabled the identification of crucial issues, existing best practices and accountable standards, which, if meaningfully reflected upon, could inform immediate interventions whilst guiding development of a more robust and sustainable national health work framework to deal with the allegations contained across all the media houses. By confronting these challenges and strengthening existing infrastructure and programs, this country is positioned to improve our service delivery, advance equitable access to quality health care, and reinforce the well-being and dignity of Botswana. It further establishes that through a myriad of administrative conduct and omissions, this country has been wanting in meeting its obligations regarding provision of adequate health services, particularly with the duty to respect the need to attain the right level of health care. But that this is largely due to the lack of a legal basis to form an entitlement to a right to health, and therefore non-compulsion to fulfill the same. This is due to an inadequate supply of ambulances, limited spaces for hospital beds in some facilities, shortage of and demoralized staff, deficiencies in customer complaints and follow-up mechanisms, shortage of medicines and medical commodities, and budgets and resource inadequacy, and the mismanagement of the same. The investigation found structural realities of overcrowded wards in certain facilities, lack of privacy, inadequate bedding, and delayed emergency response, reflecting conditions incompatible with the appropriate dignity to be accorded to patients. However, these shortcomings were found to innately undermine the principle of equality and non-discrimination, insofar as they tended to place a disproportionate burden on low-income and rural populations who rely exclusively on the public health system, thus diminishing the right to fair and non-discriminatory treatment in the receipt of public health services. Princess Marina Hospital emerged as a pivot in this investigation. The allegations concerning the facility reported in the media were substantiated upon by the investigation. The hospital is clearly operating beyond its limit and is effectively at a breaking point. In illustrating the severity of the situation, when we engaged the hospital management, they likened the facility, the PMH, to an old, heavily worn vehicle overloaded with passengers, packages, and mechanical strain, yet expected to transform the population of Botswana to a safe and healthy destination. The analogy underscored the burdens placed on the facility. Our investigations reveal that the Ministry of Health currently operates a fleet of 101 active ambulances and 87 inactive ambulances. A higher proportion of the active vehicles are over 5 years old and do not meet roadworthiness standards as prescribed under the Transport Orders and Procedures Policy. So largely they break down from time to time. And government continues to incur substantial expenditure, which I'll refer to later, on servicing and repairing the fleet in an attempt to keep the fleet mobile and transporting patients. We noted that the Minister of Health is without a policy or planning framework to determine an optimal number of ambulances required to meet the national demand, leading to the procurement of insufficient number of ambulances and utility vehicles. Moreover, such vehicles are repaired or replaced on an ad hoc basis, subject to the availability of funds. The absence of a strategy has contributed to inefficiencies, service gaps, and escalating costs. As a result, the government expends an amount of 12 million pula on private emergency medical services contracts to supplement the inadequacies of the public ambulance system. And the pattern is largely a reactive approach to emergency medical transport, characterized by a high recurrent expenditure without corresponding long-term sustainability or value for money. And in the midst of all this, the situation was compounded by the moratorium placed on the issuance of GPOs, which did not exempt the Ministry of Health and therefore disable it from acquiring speedy access to, one, the servicing of ambulances and the fueling of the same. Therefore, there is delayed timely referral and transfer of patients between facilities, resulting in delayed reception of care and sometimes adverse patient outcomes. Notwithstanding allegations of patients receiving treatment on hospital floors, the investigations found that public health facilities did not have shortages of beds as a generality, except in certain facilities such as Princess Marina, Zabon Primary Hospital, and Letlhakeng Primary Hospital. In certain hospitals, we found that there were still sufficient beds to allay fears that sick people slept on the floors as a norm. We noted a fact that is generally accepted, that Princess Marina is the busiest tertiary or referral hospital in Botswana, serving as a critical national healthcare hub in the country. Its emergency department manages a high and complex patient load of 60 to 70 patient visits every 24 hours, functioning with only 3 resuscitation bays, 9 main treatment bays, and 4 triage bays, with a complement of 75 medical staff. Currently, the emergency department has 16 medical officers, half of whom are on short-term contracts of 6 months. The department is supported by 10 emergency medicine residents, 36 nurses, normally with only about 5 working per shift, and 8 health auxiliaries. In the light of these constraints, it is clear that the emergency department at Marina is severely outstretched. Patients at Princess Marina experience waiting periods ranging from 36 to 120 hours before being triaged. So a person is referred from a hospital in one part of the country, they come to Marina, and before they go through the pre-admission process, it takes up to 3 to 5 days for them to be triaged, to be examined by a medical practitioner, and to be admitted to an appropriate ward. Pending this admission, we found that hospitals such as Scottish Livingston in Molepolle reportedly accommodated referred patients who have not been admitted. So patients will commute between the, if I were to call them the hostel hospitals, for between 3 to 5 days. Primary and district hospitals further indicated these prolonged waiting times result in extended patient stays, attracting subsistence costs for nurses and drivers accompanying the patients, as well as ambulances away from the sites, hospitals, until the patient is admitted. I must hasten to say that these long periods of 3 to 5 days were peculiar to Marina, and Nyangagwe experienced a substantially shorter time, but beyond what would have been an acceptable turnaround time for triaging and admission of patients. The reason for the prolonged waiting times and overcrowding at Marina, we found, was due to the existence of a single point of entry into Marina's emergency department, which received all incoming patients, and this created a bottleneck in patient flow. However, we also established that even if there were additional entry points, this would not resolve the deeper structural issues of inadequate space and capacity. We noted that the underlying pressure on Princess Marina is compounded by the absence of a primary hospital in the southeast districts, that is the Gaborone district, the Mogoritsane district, Tlokweng, with all patients coming into Marina for primary health care, thus straining the large patient population. Furthermore, we found that in general, the public health system only has 101 specialists, compared, for instance, with availability of the same in the private health sector, which provides 107 specialists. The figure of 101 excludes visiting personnel from the University of Botswana Medical School, which provide part-time services at Marina. Given that Princess Marina serves a significantly higher patient load than private health facilities, this lack of parity suggests a misalignment of resources. As Marina obviously serves a higher population and probably and rationally deserves highest number of specialists and supporting services. The consequence of the disparity in the numbers is that the government incurs high medical fees for referrals to private health facilities. We noted that in this financial year only, a total of 809 patients were referred to 6 private hospitals in the country. With 48% of this being ICU referrals and 52% being non-ICU. The most referred patients were for surgical treatment in areas of neurosurgery, followed by cardiothoracic and then general surgery. The government spends roughly 300 million pula on outsourcing, that is the referrals to private hospitals per annum. This is close to 6 million pula per week in referrals. And we noted that in August 2025, the Ministry of Health admitted that the government was in debt to the tune of 433 million pula plus in medical fees to private health service providers for the services that were rendered on behalf of government by the same private health services providers following referrals. The ministry also admitted that one of the contributing factors to the breakdown in health services were suspicions of maladministration bordering on malafides or otherwise deliberate abuse of administrative processes. In their own investigation into high medical fees to private facilities at the beginning of 2025, they found that medical equipment may have been intentionally tampered with, leading to referrals in private hospitals. In the year 2024-2025, the ministry reported that they collected up to 15.7 million pula in revenue from public health facilities, including user fees. Our investigation found that this figure underestimates a potential of revenue collection from public health facilities due to inconsistent practices and the absence of reliable patient records as to how many people have been attended to by public health facilities. Evidence indicates that systematic collection of user and various other fees could yield in excess of 20 million pula annually, demonstrating that revenue currently regarded as negligible is in fact material and could be leveraged to support reinvestment in the facility level improvement. This figure, in our view, could be higher if there was a generalized but modest increase in the admission fee of 5 pula that you all know has been there for decades. But as most of you know, the fee has not been collected, or it's not been collected, but also that it ought to have been raised. But of course, Botswana in general would say that the 5 pula is too much. But I've heard a cynic say that people who refuse to pay those 5 pulas can afford to pay, a cynic, not myself, they can afford to pay 15 pula or more for a curtain of shake or for a come fruit of kati, but they can't afford to pay 5 pula for a basic admission into a hospital facility. But the ministry indicated that the cost of collection of this admission fee was even higher because it included employing revenue collectors and securing the pittance collected, thereby outweighing the prospective return from the collection of such fees. Our investigations also found persistent and critical shortages of medicines and non-drug commodities across public health facilities, despite the central medical stores reporting availability levels at times of 97% for vital, essential, and necessary items. Facilities that we interviewed noted that CMS was only able to supply between 25 and 30% of items ordered. Data from the 2 referral hospitals showed availability well below acceptable thresholds and even lower availability of non-drug supplies. The Nyangagwe Referral Hospital reported a drug availability averaging 66% as of August 2025. Non-drug availability lower, with general items at 56%, specialist items at 30%, and special orders at 42%, resulting in an overall availability of 43%. Princess Marina, as at August of 2025, reflected 54% drug availability and non-drug availability, non-drug items at 79%. These shortages have persisted and in fact showing a decline, notwithstanding the interventions by the Presidential Task Team, and continue to affect the availability of essential items required for emergency and life-saving care, including intravenous fluids, antibiotics, anesthetics, and intensive care medicines, blood products, and basic medical consumables. Another area of concern that the investigation revealed was in relation to the state of laboratories in government health facilities on 2 fronts, being the level of accreditation of the medical laboratories and the state of laboratory equipment. There are serious concerns regarding the failure of many public authorities to maintain accreditation, largely due to persistent shortages of laboratory reagents and the absence, dysfunction, or obsolescence of essential diagnostic equipment. Critical diagnostic services have been compromised by non-functional or poorly maintained equipment such as imaging, sterilization, and laboratory analysis systems. As a result, the reliability of diagnostic testing and clinical decision making has been undermined. Only 5 medical laboratories had been accredited, being Athlone Primary Hospital, Botswana National Tuberculosis Reference Lab, Nyangagwe Referral Hospital Lab, Nyangagwe Hospital HIV Reference Lab, Bamangwatu Lutheran and Sekgoma Memorial Hospital Labs. We noted that Scottish Livingston Hospital accreditation was suspended in November 2025. Our investigations revealed significant deficiencies in the ministry's awareness of and ineffective oversight over conditions prevailing within public health facilities, demonstrating a marked disconnection between policy-level governance and operational realities on the ground. The deficiencies included, amongst other things, concerns such as operations of X-ray machines. For instance, an unsafe radiation levels at Hukunsi Primary Hospital was noted in the X-ray machine. The directives issued to facilities to cease using laboratory analyzers obtained outside formal procurement in the absence of policy governing donations. Even though there's no donation policy in place, the routine referral of patients for laboratory tests to distant facilities due to equipment and reagent shortages, and the widespread absence of functional autoclaves, forcing the transfer of hospital instruments across long distances for sterilization, compromising efficiency and infection control. Compounding these systemic failures, medical personnel, it was alleged, particularly in urgent cases, advised patients to procure essential medicines at their own expense, highlighting the failed oversight responsibilities, the duty to procure or to provide medicines, and the lived realities of service delivery within the public health facilities. We noted that the government has spent close to 283 million, 107,000 pula from the period 2021 to 2025 on in-service training for specialized personnel to resource both primary and district hospitals with specialists, with a view to decongesting the referral hospitals. But we found that following training, these specialists would leave the public health care system for better and greener opportunities, mainly because they faced burnout from impossible workloads, lack of support, and no access to tools of trade. They indicated experiencing moral distress whilst knowing what good care looks like, but being unable to provide the same. The outcome of our investigation is that we have come up with 36 recommendations grounded on administrative and human rights principles. Some may be adversary in nature, but many require deliberate and urgent implementation, guided by ensuring that proper public administrative principles and respect for human rights are interdependent, and compulsory obligations on the part of the state. The primary, or the initial recommendation is that we believe that this country has reached a turning point and a fork in the road where there is a need to ratify and domesticate the International Covenant on Economic, Social, and Cultural Rights, being the primary international instrument explicitly recognizing the right to the highest attainable standard of physical and mental health under Article 12 thereof, to enable enjoyment of a full legal and enforceable right to health at the national level. This recommendation is made on the backdrop of an obligation on the part of the Ombudsman to advise the government to appropriate, for the government to ratify and accept appropriate international instruments and conventions. We also advise that government should ensure allocation of sufficient budget to the Ministry of Health to enable the ministry to do the following. For the ministry to prioritize the development and establishment of a primary or district hospital within the Gaborone district area to decongest Marina Primary Hospital, and to ensure that non-critical and outpatient cases are properly redirected to lower tier facilities. In the interim, the hospital should increase the number of patient access points at the emergency services room through strategically placing adequate triage stations, outpatient intake areas, and specialized clinics. The ministry should target expansion of hospital wards in the public health care facilities identified as operating beyond capacity to reduce congestion and improve access to health care, particularly at Princess Marina Hospital. And the ministry should immediately fill all the critical vacancies in the Ministry of Health as well as the public health facilities, e.g. the appropriate number of intensive health care nurses, ophthalmic nurses, radiologists, pharmacists, cleaners, revenue collectors, etc. The ministry should arrange and institute a fast-track approval for contract renewals for essential workers employed on short-term contracts, having noted that many of them are employed on contracts that expire, and it takes a very long time, up to 6 months, to re-engage them. Therefore, there's a need to ensure that there is seamless re-engagement of such staff, and that the ministry, together with the DPSM, allow such contracts to continue seamlessly while past paperwork is being processed, so as to avoid disruption of service delivery in the public health sector. We also have the view that whilst, and this is a recommendation, whilst consultations are ongoing for the National Health Insurance Policy, designated revenue collectors should be employed to ensure collection of revenues through collection of user fees and other fees in public hospitals. That there's a need to introduce, where there are no revenue collectors or safety boxes, mobile payment and digital billing systems to enable the collection of any payments due for delivery of services in the health sector, and to modernize hospital revenue collection systems, especially after 4:30 p.m., where many patients come in, and there are no revenue collectors to collect payments. That there is a need for the ministry to publish periodic reports on the availability of essential medicines and medical supplies at all times to ensure transparency and accountability in the delivery of the healthcare services during the crisis that we are going on and thereafter. That the ministry should conduct a comprehensive assessment of the impact of medical and non-medical commodity shortages on patient outcomes, including potential for mortalities or deterioration of health conditions of patients admitted into the system. That the Ministry of Health should address persistent shortages of medical officers, nurses, and other staff, and to ensure accelerated recruitment drives and provide adequate retention incentive measures, particularly for those serving in remote areas. The ministry should undertake a country-wide audit of medical equipment to assess functionality and to prioritize maintenance, repairs, and replacement of equipment, and to provide a cost plan to guide government on budget and resource allocation respecting medical equipment in the hospitals. That there should be a policy on disposal of obsolete and dysfunctional medical devices and equipment to ensure that these are out of the facilities to free up space in the labs, because we noted that the labs were crowded with non-functional or obsolete equipment. And as indicated in the case of Hukunzi Hospital, where there was a non-functional X-ray machine that leaked X-ray radiation. The ministry should prioritize and redirect the funds currently spent on referring patients to private healthcare facilities towards employing specialist medical personnel within the public health system, and invest in in-house expertise with a view to reducing costly external referrals and to improve timely access to specialized care and build sustainable capacity in the public health sector. This is a few of the recommendations among the 36 that I have referred to, which are in the full-length report, which we will avail very soon. In the next, I don't know how many hours, my team will be able to share it with you. This own motion investigation has revealed serious and systemic failures within the government system to provide budgetary allocation to the Ministry of Health to enable it to provide quality public health care. And that this has materially undermined constitutional and international obligations to ensure availability, accessibility, acceptability, and the quality of health care, goods and services to the general public. We believe that a meaningful compliance with the recommendations that we have made to the ministry will restore effective administration, ensure patient safety and dignity, and prevent the recurrence of maladministration in the delivery of public health services. I must hasten to say that this investigation took a period of 6 months. It was not a private investigation. We engaged over the 6 months continuously with the Ministry of Health. We verified facts and data. In fact, the past 6 weeks, or almost 8 weeks, was largely taken up by verification of facts between my team and the Ministry of Health teams. I engaged personally with the PS of Health to ensure that we did not misrepresent facts and situations. I thank you, Director of Ceremonies. Thank you. The report will be available, the full length report will be availed soon. Thank you.
And that ends the live broadcast of the report by the Ombudsman on the state of our health care. And I think that follows again or goes on to stamp on the spot checks done by the President, Princess Marina, and subsequently to the Circuit Marina Hospital. From here, we're watching our news in Afrikaans.
Bagaitso, hurt people